Hi everybody, this is your supplemental lecture for the abdomen. Here's a great picture in terms of the anatomy of the abdomen, and when it comes to any assessment, any body system, it's always important to know anatomy physiology. If you know your physiology, you'll definitely be able to figure out your differentials based on your assessments. But it's important here in terms of the landmarks of the abdominal wall and the pelvis that you kind of visualize this as you're assessing your patient, and then assessing specifically when with palpating. A little key trick here to know is that the abdominal muscles will become more prominent when you have the patient raising their head and shoulders from the supine position. So this is why it's important that we have a nice soft abdomen when we're palpating. I always find it very helpful, especially when you're studying, to divide up the abdomen into the 4 quadrants. Of course, that's important for your documentation purposes, but also for those that especially that need some review in terms of which organs are where. By dividing them up into the quadrants, it kind of breaks it up into little bite-sized pieces in terms of, okay, so as you're studying the right upper quadrant, which organs are there, and or the left lower quadrant or what have you. But this way, it kind of helps making your studying a little bit easier, but at the same time, of course, you need to know it for your documentation. Well, that, and of course your physical exam, of course. Also dividing the abdomen into 9 sections. The 3 that are most commonly used when you're looking down the middle there is the epigastric, umbilical, and suprapubic. I don't usually hear it called the hypogastric too often, but however, in obviously this book and other resources, you might also see it as hypogastric. So then when you actually get down into the organs of the abdominal cavity, it's important, again, just to know where things are at and what should be palpable. Like, so for example, if you're looking through like kind of a clockwise rotation, there are going to be a few organs that are often palpable. Of course, exceptions are the stomach and most of the liver and spleen. So if you think about it that way, if it was palpable, then you might consider there's an issue going on. So just going around, starting with the right upper quadrant, the soft consistency of the liver usually makes it difficult to feel through the abdominal wall. Think about the gallbladder, and that rests against the inferior surface of the liver. And then, of course, more deeply, the lying duodenum are generally not palpable. But at a deeper level, the lower pole of the right kidney Moving along into the history taking of the abdomen, we know that a lot of GI issues bring people in to be seen, whether that be an office or, say, the emergency room. A lot of common or concerning symptoms when it comes to the GI tract. Of course, pain, whether that be acute or chronic, indigestion, nausea, vomiting, dysphagia, change in bowel function, diarrhea, constipation, and jaundice. So when it comes to history taking, we want to ask, hey, how the regurgitation is the reflux of food and stomach acid back into the mouth. Has like a brine-like taste. Dealing with vomiting. Now you can have obviously vomiting with emesis itself, or retching, and that's the act of, say, you're going to vomit, the spasmodic movement of the chest and diaphragm, like you're going to vomit, but nothing comes up. If the patient does have some sort of emesis, you want to ask about the amount. And what type? What does it look like? Does it look like last night's dinner? Does it look like a green or yellow bile? Does it have a mucus texture to it, or does it look like mucus, any blood? And of course, you want to ask if that's what color of blood is it? Is it bright red, which would mean that it's upper GI versus a coffee ground look to it, which is often a lower GI, so old blood. In terms of pain, you definitely want to be able to qualify the patient's type of pain. When it comes to visceral pain, this is when hollow abdominal organs such as the intestine or, say, biliary tree contract unusually forcefully, or there's a distension or stretched. Now, solid organs such as the liver can also become very painful when their capsules are stretched. And now visceral pain may be very difficult to localize. It's typically palpable near the midline at levels that vary according to the structure involved. When you're looking at, say, the right upper quadrant, that might result from a liver distension against its capsule in, say, a patient that has alcoholic hepatitis. If you have visceral pain in the periumbilical area, that might signify an acute appendicitis from the distension of the inflamed appendix. And then, of course, that will gradually change into a parietal pain, which we'll move into here. And that's where there's inflammation from the hollow or solid organs that affect the parietal peritoneum. So parietal pain is more severe and is usually easily localized, whereas visceral pain, difficult to localize, where parietal pain, easy to localize. Referred pain, that originates from different sites. So, for example, gallbladder pain, a lot of times will have pain in their shoulder. And here's a nice diagram that's also found in your book in terms of where you might also find other types visceral pain. So depending on where in the abdomen, finding the different types of visceral pain there based on location. As you continue your history taking, having the patient describe their pain or their symptoms in their own words. This goes across, doesn't matter which body system you're assessing, but having the patient to give them their own words is great for your documentation, so you can put that in quotes. I like to have the patient point with one finger in the area, and the reason why I have them do with one finger is because instead of their whole hand, it's hard to say that, a whole hand might cover a complete quadrant. Now that might be the case, but I like to know specifically where is the pain, and that also helps me when I go down to asking about radiation. So I ask the patient, point with one finger where you're having the most pain. They'll point with their finger, and I say, does that pain move anywhere? And then with that one finger, they can show me where that potentially moves to. So it'll also help me determine if it's a referred type of pain as well. Of course, you're always asking on the severity of the pain scale. 0 to 10 is what I like to say, because if the patient is not in pain at the moment, maybe they were having pain earlier and that's what brought them in. If this pain's been going on for some time, if it's intermittent, for example, a lot of texts will say on the scale of 1 to 10. But 0 is a number, and this, of course, is just my own pet peeve in terms of when you're assessing a patient, asking them to rate their pain on a scale of 0 to 10. Because if they're not having any pain right now, then they can say 0. But if you only give them the option of 1 to 10, then that's telling them that they must be in pain right now. Asking about timing, what brings on the pain, what were they doing when the pain came on? How often the pain is it constant or intermittent? How long does it last when it comes around? So that's duration. We talked about radiation. And then asking if anything that they do makes the pain better or worse. And then asking about any symptoms that are associated with that pain. It's always important to ask the patient about their bowel movements. A lot of times you'll get this. Moving on, asking about any prior medical problems that might be related to the abdomen, any history of hepatitis. Of course, when it comes to hepatitis, being able to determine which hepatitis, and they'll be able to tell you. For example, so with hepatitis A, that's usually when people travel or have something with poor sanitation, or they have some sort of contaminated food or water. That's hepatitis A. Hepatitis B, we should all be familiar with in terms of if you're working in healthcare, most likely that you've had the boosters, the immunization for hepatitis B as a healthcare provider, and we know that that's exposure to infectious body fluids. blood, serum, semen, saliva. This is common through sexual contact with an infected partner or use with shared needles for drug injection. And then hepatitis C, we know, is IV illicit drug use or blood transfusion most commonly. There's the alcoholic hepatitis or alcoholic cirrhosis. So you want to make sure that you're having a really good interview with the patient. If they have liver damage prior to due to medication use, sometimes they'll have some other environmental toxins associated with that. Asking about any gallbladder problems, so any diseases or surgeries. Of course, you would do a nice surgical history as well. And then any hereditary disorders due to their family history. So we mentioned the prior surgeries, about foreign travel, that can help you associated with any, if say they have no history of hepatitis, but they were talking about foreign travel, and then after they ate the food, that's when they started having the symptoms. That might help you there. Of course, doing a social history in terms of the tobacco, alcohol, and drug use. And we also just mentioned about the hereditary issues. When it comes to urinary tract, again, asking about the frequency, how often do they urinate, do they have feelings of urgency, meaning that I feel like I have to urinate, they go to the restroom to then urinate and very little urine comes out. I wanted to ask about any pain with urination. We call it dysuria, with there's that burning in the urethra or aching in the suprapubic area of the bladder. I want to ask about the color and the smell of the urine. Is there any pink tinge to it, or any actual frank blood that would be considered a hematuria? Of course, when you're doing a urine dip, sometimes this will be seen microscopically. In men, you want to ask about the difficulty in starting the urine, and obviously also asking about the urine stream. Is it one continuous flow, or does it kind of smatter in different directions? Also asking about any leakage of urine, so any incontinence, especially in women. Of course, differences if they're pregnant or not, and obviously their age. Stress incontinence usually will rise from a decrease in intra-urethral pressure. So this is where we want to educate our patients on the Kegel exercises. So if there's any involuntary voiding or lack of awareness that they're urinating, which suggests that there's a cognitive or neurosensory deficit. So that's super important. You also want to assess and then ask about any back pain. So if there's any kidney issues there, so like for example any kidney disease. Of course, we mentioned about the CVA tenderness, and of course lower back pain. That can be potentially referred pain in men. And of course, also in men, you want to ask about any symptoms that they're having in their penis or their scrotum. Okay, when it comes to inspecting the abdomen, you want to look for any skin. Well, of course, you're looking at the skin, but you want to look for any scars on the skin. This can be indicative of, say, for example, if the patient is coming in with right lower quadrant pain, one of the questions you might ask previously, do you have your appendix? If they say no, and then you're inspecting their abdomen, a lot of times this is happening all at the same time, you might see a pretty large scar. That also, back in the day, old school method really was an open method of getting rid of the appendix or removing the appendix. But nowadays, depending on if it was an emergent or not, you might find the laparoscopic scars on the abdomen. Sometimes those are a little difficult to see, depending on body morphology and how long ago it was. But nonetheless, that can be helpful in determining if there's any previous surgeries there. Any stretch marks or striae, looking at the vein pattern, any hair distribution, and of course any rashes or lesions. You want to look at the umbilicus, so observing the contour and location. Sometimes post-surgery location might be a little bit in different areas. Of course, looking for any type of hernia. Again, the contour of the abdomen, part of your normal documentation. Is it flat, rounded? Is it protuberant? Is the abdomen symmetric? You want to inspect for any signs of peristalsis, in which we know that's like the snake-like movement or the rhythmic movement of the intestine. In very thin people, you might be able to see that, but most commonly you will not. With most body morphologies, and of course, any pulsations. Again, depending on body morphology, you might be able to see the pulsations of the aorta. Now, it's always important to auscultate before you palpate or percuss. So why is that? Of course, that's because we don't want to give some extra sounds potentially if we're moving organs around and kind of upsetting them a little bit, and then we auscultate. We might, for example, say the patient has hyperactive bowel sounds, whereas maybe they weren't so hyperactive before we were palpating or percussing. You also want to place the diaphragm over the abdomen again to hear those bowel sounds. You also want to listen for the aorta. Over the aorta, the iliac and femoral arteries. You're going to assess for bruits. So a bruit in one of these areas that has both a systolic and diastolic component will usually suggest renal artery stenosis, and that can cause hypertension. And about 4% to 20% of healthy individuals will have an abdominal bruit. You also want to place the diaphragm over the liver and the spleen to listen for friction rub, because we know that friction rubs are usually present in hepatomas, gonococcal infections around the liver, splenic infarction, and pancreatic carcinoma. So here's a quick question for you. What is the preferred order for examination of the abdomen? Is it A, inspection, auscultation, percussion, palpation? B, percussion, auscultation, palpation, inspection? C, auscultation, inspection, palpation, percussion? Or D, inspection, palpation, auscultation, or percussion? And we know that it's A. Inspection, auscultation, percussion, and palpation, because we know that you must always auscultate before palpating or percussing. So moving on to percussion, this helps you assess the amount and distribution of any gas in the abdomen, any possible masses that are solid or fluid-like, and the size of the liver and the spleen. So we know that tympany is a hollow sound, where dull is more of a sound that you'll hear over an organ, like a full organ such as the liver. Now, you want to percuss the abdomen lightly in all four quadrants. This will help you assess the distribution of the tympany or dullness. Now, tympany is usually predominant throughout the abdomen because of the gas in the GI tract, but then you'll have scattered areas of dullness from any fluid and feces, which are very common. You want to note that any large dull areas would suggest either an underlying mass or an enlarged organ. Of course, observation will guide your palpation. So say, for example, if a patient has a protuberant abdomen that's tympanic throughout, that might suggest an intestinal obstruction. Dull areas can indicate, of course, a pregnant uterus, for example, an ovarian tumor, a distended bladder, or even a large liver or spleen. Dullness in both flanks promotes further assessment for ascites, which we'll talk about momentarily. And very rare condition of situs innervus, which is the organs are reversed. You'll have an air bubble on the right, and whereas the liver dullness is on the left. Again, that's very, very rare. You want to briefly percuss the lower anterior chest just above the costal margins. On the right, you'll always have that dullness of the liver, and on the left, the tympany, which is usually have like a gas air bubble there, and then the splenic flexure of the colon. So we know that mid-clavicular percussion should be about 6 to 12 centimeters. If it's any longer, then that's going to indicate an enlarged liver. From mid-sternal line, it should be about 4 to 8 centimeters, and that's shorter because, or any shorter than that, rather, can be, indicate a small, hard, and cirrhotic liver. There's two ways that you can percuss the spleen. So by percussing the left lower anterior chest wall between the lung resonance above the costal margin. If it's dull here, that can indicate an enlarged spleen, because usually the tympany is supposed to be present. And usually when you hear the tympany, splenomegaly is not likely. You can also check for the splenic percussion sign, and that's where you percuss the lowest inner space in the left anterior axillary line. This area, again, usually tympanic. If the spleen is a normal size, again, still remains tympanic. However, if you hear some tympany that moves into dullness when the patient breathes in, that would suggest an enlarged spleen. And this is considered a positive splenic percussion sign. With palpations, you always want to start light, and then before you move into deeper palpation. And this can help identify the superficial organs or any masses. Obviously, you're looking for any voluntary guarding, meaning the patient will consciously flinch when you go to touch them. So if you considered that, say you had a stomach ache, and then I went to go palpate your abdomen, you're gonna flinch. You're gonna try to guard yourself, just as a protective measure. That's, of course, versus involuntary guarding. That's where a muscle spasm when you actually touch the patient, but they can't control it. So again, are they controlling it or are they not? Again, too, you also sometimes, which we'll talk about a little bit with special considerations, sometimes a patient might be a little ticklish. And with that, if they happen to be a little ticklish, you can always have the patient with their hand. You can have the patient place their hand on the abdomen, and then you can then push on the patient's hand. Of course, other ways to relax the abdomen area, because again, here you're assessing whether it's a voluntary guarding versus involuntary. You can have the patient breathe out deeply. You can even tell the patient to breathe through the mouth and then with the jaw dropped open. Then you move on to deep palpation. So, for example, you want to start with the light just to get the superficial organs, and then you'll start to palpate deeper. What you're looking for here, too, is rebound tenderness. And what rebound tenderness is as you are palpating the patient, there might be some pain there, but when you decrease the pressure on the abdomen or you let go, there'll be an increased pain, and that's considered rebound tenderness. Now, textbook classic symptom of that is with your appendicitis. You can also palpate part of the liver, so using one hand to support the back at the level of the 11th and 12th rib. Then your other hand will then press on the abdomen inferior to the border of the liver and continues to palpate superiorly until the liver border is palpated. Now, best way to do this is have the patient take a big breath in, and then as they are breathing out, you're able to then sometimes get under that rib to be able to feel those borders. So any firmness or hardness of the liver, or any bluntness or rounding of its edge, and it feeling irregular, would suggest some sort of abnormality of the liver. There's that hooking technique may be helpful, and this is especially when the patient is obese. So you want to, for example, stand to the right of the patient's chest and then place both hands side by side of each other on the right abdomen, just below the border of the liver dullness, because again, you've already percussed to try to figure out the dimensions. And then press with your fingers up and towards the costal margin. And then ask the patient, again, taking a deep breath, and then this can help with the figuring out the liver edges. The edge of an enlarged liver may be missed if you start palpating too high in the abdomen. Now, there's a very good of what I just mentioned there, and of course, step-by-step instructions in your book, which is excellent. Now, again, normally spleen, you can't feel the spleen, but if you feel maybe the splenic tip, that would indicate splenomegaly. Moving on to palpating the left kidney, you can do that on both sides, left and right, again, depending on body morphology of the patient. And your book describes this in detail on how to do so. Like we mentioned before, if there's a protuberant abdomen with on both sides, on the flanks, you would consider it ascites, and ascites is that fluid in the abdomen from such diseases as cancer. So ascites will occur in increased hydrostatic pressure in cirrhosis of the liver. Sometimes patient will have heart failure, constructive pericarditis, or even inferior vena cava or hepatic vein obstruction. So this might signal a decreased osmotic pressure in nephrotic syndrome and malnutrition and ovarian cancer. So in ascites, dullness will shift to the more dependent side, whereas tympany shifts to the top. And again, we know that tympany is where you'll have that fluid. So due to gravity, that dullness should be located along the lateral sides of the abdomen if you have them in a supine position. So of course then if fluid shifts to the lateral, then anterior portion should be then tympanic. If you want to test for the shift in that dullness, after kind of mapping out where the areas of tympany and dullness are, you can have the patient roll to one side. And having them do that, if they have the fluid in ascites, there should be a shift due to the free fluid moving with the gravity. You can also test for a fluid wave, and that's basically you can have either yourself, your assistant, or even the patient press their hands firmly down in the midline of the abdomen, almost making a dam. For example, if you're thinking, like, say, of a river dam, then you can have the you can tap then on one side of the flank, and then you can feel with your own hand if there's a wave of that fluid on the other side. So dealing with appendicitis, one of the very common things that will come in to see you, depending, of course, where you're working. Looking for that involuntary guarding, looking for that rebound tenderness, again, all in the right lower quadrant. You can also perform a rectal exam and a pelvic exam, so rectal in both sexes and pelvic in female. Generally, this is not usually the first go-to if they're having this type of pain, but of course, if your assessment warrants it, then you could go for it. You can check for roving signs, and that's rebound tenderness in the left lower quadrant. So thinking about that referred rebound tenderness. Then moving on to psoas sign, this is where you'll have the patient flex their thigh against your hand, and if there's pain, then that's a positive psoas sign. And that's because flexion of the leg at the hip makes that psoas muscle contract. Extension will then stretch it. So any movement of the psoas muscle will cause that pain. And then the obturator sign is another one. You can flex the patient's thigh and rotate the leg internally at the hip. And any pain, of course, is a positive sign. Again, your book has great descriptions of all this as well.